All right, today we're tackling something absolutely critical in nursing: increased intracranial pressure. Look, when the brain is under pressure, every single second counts. Your actions, what you do at the bedside, can literally be the difference between a good outcome and a catastrophe. So let's break down exactly what's happening inside that skull and what you need to do.
You have to burn this sentence into your brain because it is the key to everything. Unlike, say, a swollen ankle that has room to expand, the brain has absolutely nowhere to go. That rigid bony vault, the skull, is both its greatest protection and, when things go wrong, its most dangerous prison.
So, this brings us to a fundamental rule, the Monroe-Kelly doctrine. And listen, this isn't a suggestion, it's a law of physics for the head. Think of the skull as a sealed box. It has a fixed volume. Inside, you've got three things: brain tissue, blood, and cerebrospinal fluid, or CSF. If one of those things starts to take up more space, one of the others has to get squeezed out to keep things stable. It's a zero-sum game. Okay, let's actually draw this out, like we're at a whiteboard. We're going to map out how a seemingly simple injury can kick off a life-threatening pressure crisis, step by step. And we're going to focus on the why each change leads directly to the next. So, when everything's fine, this is what we're looking at inside the skull. The brain tissue itself takes up about 80% of the room. That other 20% is shared between the blood that's flowing through it and the CSF that's cushioning it. Everything's in harmony, a perfect, stable equilibrium. And then, bam. A car crash, a nasty fall, a stroke, something causes a traumatic brain injury. Suddenly, you've got this intruder, a bleed, maybe some swelling, that's just barging in and taking up space. That fixed volume we talked about, it's just been violated. Now, the body is no dummy. It knows something's wrong, and it tries to fight back. It kicks into compensation mode. It starts shoving CSF out of the skull and down the spinal column. It clamps down on blood vessels to reduce the amount of blood in the head. It's scrambling, trying to make room for that new swelling. But here's the catch: it can't do this forever. And that's the scary part. There's a tipping point. Once the body has pushed out all the fluid it can, well, there's just no more room left to give. The system fails, and that pressure begins a dangerous, almost vertical climb. This is the moment where your sharp assessment skills become everything. Okay, let's talk numbers. These are the numbers you have to know. Normal intracranial pressure, or ICP, hangs out between about 7 and 15. But once you see that monitor tick past 20, man, that's when the alarm bells in your head better be screaming. That's your signal that compensation has failed, and we need to intervene right now. All right, get your highlighters out for this one, because this is a massive exam trigger and a crucial bedside tool, the Glasgow Coma Scale. As pressure goes up, the patient's level of consciousness goes down. And there is a phrase in nursing that you need to tattoo on your brain: less than 8, intubate. A GCS score of 7 or less tells you the brain is feeling so badly the patient can't even protect their own airway anymore. So as that pressure is literally squeezing the brain, we start to see these really disturbing, almost primal physical signs. This is called neurological posturing, and it's something you will see with your own eyes right at the bedside. Okay, so there are three main types you've got to be able to spot. First up is decorticate. Think core. The arms are flexed inward toward the core of the body. That's bad. But then it gets worse. You might see decerebrate posturing. Now the limbs are extended and rigid at the sides. This tells you the damage is deep, down in the brainstem. And finally, flaccid. Just nothing. No muscle tone at all. That's catastrophic neurological failure. We're reaching the climax of this crisis now. The pressure is continuing to climb to this lethal peak, and it starts to physically crush the brain's command center, the brainstem. You know, the part that controls breathing, heart rate, blood pressure. The body is about to send out its final desperate SOS. So that leads to the critical question. What's the ultimate mayday signal? What's the final red flag that tells you the brain is literally about to be forced out of the skull? The answer is Cushing's triad. This is the big one. The absolute do-not-miss red flag emergency. It's a set of 3 signs: a widening pulse pressure, a plummeting heart rate or bradycardia, and crazy irregular breathing. But let's not just memorize it. Let's understand why it happens. The brainstem, starving for blood, jacks up the systolic pressure to force blood flow up. This crazy high blood pressure triggers a reflex that tanks the heart rate. And all the while, the respiratory center is getting crushed, making breathing erratic. That's the why behind the triad. Okay. It looks bleak, I know, but this is not the end. This is where you come in. This is where our nursing interventions can literally stop this deadly cascade in its tracks. There are specific things you must do right now to get that pressure down. First thing, get that head of the bed up to 30 degrees. Not 20, not 40, 30 degrees. We're using gravity to help drain fluid. Second, no Valsalva maneuvers. That means no coughing, no straining on the toilet. Anything like that can cause a huge, deadly spike in pressure. Third, control that fever. A fever cranks up the brain's metabolism, which makes the swelling even worse. Keep them at a normal temperature. And finally, keep that spine aligned, head and neck in a straight line, no kinking the hose. We need that drainage pipeline to be wide open. And of course, we're not just doing physical things, we're hitting it with pharmacology. We give powerful diuretics like mannitol. Its whole job is to act like a sponge and pull fluid right out of the brain tissue. We use corticosteroids to fight that inflammation. And since a brain under this much stress is a seizure waiting to happen, we give anti-seizure meds to prevent it from having one.
Okay, that was a ton of information. I get it. So let's do a super quick 30-second visual recap to lock it all in and put all the pieces together.
So we start in balance, equilibrium. Then, bam, an injury throws a wrench in the works, adding volume. The body tries to compensate, shifting fluid around, but it's not enough. Compensation fails, and that ICP shoots past 20. Then comes the final warning, Cushing's triad, signaling that herniation is right around the corner. And that's our cue, the moment for intervention to slam on the brakes and save that brain. And really, that brings us to the whole point of this. You, as the nurse, are the last line of defense. You are the final guard standing between pressure and perfusion. You're the one at the bedside who's going to see that first, tiny little change in their level of consciousness. So the question is, when you see it, are you going to be ready to halt the cascade?